Hello, and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shanmugam. Sometimes in life, you encounter multipliers. These are often people or events that cohesively integrate and unite, bringing things together, making them more than the sum of their parts. Context is important, and while we may attribute good outcomes to luck, often a constellation of seemingly unrelated events contributes in multiplicative ways. Anyone who's ever been running late in clinic also knows the flip side is true. Small issues multiply negatively, and one thing leads to another as your day spirals out of control. It turns out the same is true for health outcomes. The manuscript we'll discuss today is Multiplicative Impact of Adverse Social Determinants of Health on Outcomes of Lupus Nephritis, a meta-analysis and systematic review. It was published in Arthritis Care and Research, and a link to the manuscript and disclosures are in our show notes from today. I'm delighted to be joined by the first author, Dr. Shivani Garg. Dr. Garg is an assistant professor of medicine in the Division of Rheumatology at the University of Wisconsin School of Medicine and Public Health. She graduated top of her class from the Government Medical College and Hospital in Chandigarh, India, completed her residency at Einstein Medical College in Philadelphia and rheumatology fellowship at Emory University in Atlanta, Georgia. During her fellowship, she received the Best Speaker Award from the Georgia Society of Rheumatology Scientific Meeting. She's been involved in several studies focused on the clinical epidemiology of lupus, and she's focusing her research on the burden of renal atherosclerosis in lupus nephritis patients and medication adherence for patients with lupus. She's currently the medical director of the University of Wisconsin Lupus Clinic, the only clinic in Wisconsin focused on providing comprehensive care for people living with lupus. Welcome to the show, Shivani.
Thank you. Thank you, Vicky, for the introduction and for inviting me to the show and for this opportunity.
So I wanted to begin our discussion today with some background to this study. We know that lupus is more common in women, and we know it can be life-threatening. Lupus nephritis affects about 35% of people at the onset of lupus, and up to 60% of people with lupus will ultimately develop lupus nephritis over the course of the subsequent 10 years of disease. So tell us why studying social determinants of health in lupus is important.
Yeah, so lupus, as we all may know, it is a disease, or it is one of the most severe life-threatening autoimmune disease that disproportionately affects young women and people from certain social groups. We know that people of Black race have a significantly higher risk of getting lupus, as well as patients who are experiencing social barriers. They do have poor outcomes. What is most striking is that all the poor outcomes that we see, including the risk of having heart attack, stroke, kidney failure, or higher mortality burden in certain patients of certain racial groups or social groups, only 10 to 30% of these outcomes could be associated with genetics or biological factors. So this brings us leaves us with a very important question on what are the key drivers of such poor outcomes that we are seeing in such young patients with lupus and lupus nephritis. That got us thinking that about social determinants of health. Not that we are the only ones who are thinking about it, but there have been a lot of studies that have been going on about social determinants of health, which are the social factors or the environmental factors that we are living in, and they contribute to our health and could interplay with some biological factors and lead to the poor outcomes or the disproportionate poor outcomes that we are seeing in patients with lupus and lupus nephritis. So that was the main reason that we wanted to sum up all the literature that has been published thus far on social determinants of health or social factors and their interplay with some of the biological factors that could provide some explanation and also future direction of for other studies to look into lupus and lupus nephritis outcomes, and also how we can improve outcomes in patients with lupus and lupus nephritis, and finally advance health of these young patients.
So this work was a systematic review, and systematic reviews have a very specific methodology. Full details of your protocol are listed on Prospero. Tell us how you approached this literature search and screening the manuscripts. What did you include? What did you exclude? And how did you assess the quality of the studies you were reviewing?
For systematic review, we first had our objectives defined. What were the primary outcome, or like primary aim of the study that we were looking at? Our objective was that we wanted to look at different social determinants of health. If they are present, what are the effects are on the outcomes in lupus nephritis? We defined our outcomes as any severe poor outcome that includes either a patient having kidney failure, requirement for renal replacement therapy, that could be dialysis or transplant, or patients experiencing a heart attack or stroke, so cardiovascular disease event, and then mortality, early death or premature death in patients. So these were the primary outcomes that were a priori defined for the study. And then for the screening, once we had our outcomes or objectives in mind, the next step was to define the explanatory variable. So for the explanatory variable, we defined, we wanted to look at social determinants of health. So we looked at different social determinants of health, specifically looking at different frameworks. We included all different social determinants of health that were defined or explained based on different frameworks. And then we had different domains for social determinants of health with different factors included in each domain. For example, we had individual social determinant of health domain that included socioeconomic factors, which were at individual patient level or person level, including income, would include housing instability, economic insecurities, etc. Then we had neighborhood or community. So in the neighborhood, how those factors affect, for example, neighborhood income or median socioeconomic status of the neighborhood was included in that category. And then we had healthcare access as another domain. Healthcare as another domain, which had access, care quality, care fragmentation as some factors included. And then the final domain was health related behaviors that included smoking, alcohol use, illicit drug use, etc. Once we had defined our outcomes, explanatory variables, the next step was to define our inclusion-exclusion criteria before we go to literature search. So we had our inclusion-exclusion criteria based on our explanatory variable and our outcomes, where we wanted to include full text papers where the text was available. Outcomes were based on our a priori defined outcomes. Patient population was lupus nephritis, and then finally the explanatory variable or a variable that was studied was social determinant of health, which might fall into any domains that we talked about. Then we did aggressive step-by-step approach or systematic step-by-step approach for the review. We defined our research question that we got help from a librarian and ensured that the research question was saturating, all was enough and was capturing all studies that were done. So we ran the research question or the search question for different search engines, including PubMed, Web of Science, and similar Embase, clinicaltrial.gov. So we did the same search question, ran it in different search engines, and made sure that we were getting similar results. Once we had our screening list, then 2 independent reviewers went over the screening list by title and abstract review. Using our a priori defined inclusion-exclusion criteria. That gave us a list of studies that will be full text will be reviewed. And then we reviewed full text, again, made sure that these studies met the inclusion criteria. And then finally, we had 31 studies that we included in the meta-analysis and systematic review and performed data abstraction. Then the data was pooled and analyzed using random models, random slope models, and forest plot were created. The quality of study is important for any systematic review because that defines whether the studies that were included were good quality. Were there any risk of bias in the studies, in order to like drive a good conclusion from the pooled studies? So for quality assessment, we use two standard or gold standard tools. One for observational study, which is the Newcastle Ottawa scale, NOS. And then for the randomized control trial or any intervention based study, we use the CCRA, which is the Cochrane Collaborative Review Assessment Tool.
Great. And you told us a little bit about the social determinants of health that you looked at. Can you give us a bit more granularity on the specific adverse outcomes of lupus nephritis that you were interested in?
Yeah. So for adverse outcomes, we focused on the severe outcomes, outcomes that affect quality of life, that might affect patients' functioning or could affect their survival. So the key severe outcomes that we were interested were cardiovascular disease, any clinical cardiovascular disease event that included either a patient had myocardial infarction, angina, or a stroke or a TIA. So again, like defined by the studies, but that was one of the outcomes that we looked at. So clinical cardiovascular disease events defined by the study. And then the next one we looked at was end-stage kidney disease. So end-stage kidney disease was defined by as kidney failure that required renal replacement therapy. So a requirement of patients ending up on hemodialysis, peritoneal dialysis, or requiring kidney transplant. So that's how we defined end-stage kidney disease. And then finally, the last outcome was knowing that patients with lupus nephritis have 12 times higher, 6 to 12 times higher standardized mortality rate. What it means is that these patients are at 6 to 12 times higher risk of mortality compared to their age-matched healthy peers. So in those, so that was another outcome that we looked at. So premature death, accelerated risk of death. So studies looking at mortality were included as an outcome. And then one of the outcomes, which was not a main outcome of the study, but still included, was chronic kidney disease. The reason it was not included as a main outcome was there was heterogeneity in how studies define chronic kidney disease. Some studies defined that as lupus nephritis progression. Some studies defined chronic kidney disease as change in EGFR or kidney function. And so there were like very variable descriptions or like definitions for chronic kidney disease in different papers. So that's why the studies were very heterogeneous and limited. And thus, the chronic kidney disease was not included as a main outcome. And it was also not considered as a severe outcome, as severe as having kidney failure, heart attack, or clinical cardiovascular disease event or mortality.
Yeah, that's really helpful. Thank you for that description. So as we think about moving on to the results, as we think about systematic reviews, you always begin with this huge number of manuscripts to look at, but very rapidly it gets whittled down. Did you say only 30 manuscripts were finally included in the abstraction for this analysis?
Yes, 31 were included in the final data abstraction.
So you were, however, able to pull quite a bit of data from those 31 manuscripts. I wondered if you could start taking us through it. What did you find? Were the outcomes of lupus nephritis correlated with adverse social determinants of health?
Yep. So we got 31 manuscripts, and then interestingly, we had a good distribution of studies done not just in the US, but also other countries. And I just wanted to acknowledge all the researchers who did contribute to or like share their de-identified pool data for us to run some of these numbers. across the globe. So I wanted to highlight first that what we did for the analysis was that for the first and foremost question that we wanted to answer was if any having any adverse social determinant of health or adverse social factor was associated with higher odds of having severe lupus nephritis outcome or a poor outcome in lupus nephritis. So for that, what we did was that if any study had looked at any social determinants of health, and we were able to pull that data, we ran a forest plot, or like we ran a meta-analysis using R and created a forest plot. The first analysis looked at patients who had any adverse social factor or adverse social determinant of health. What were their odds of having a poor outcome compared to patients who had no abnormal or adverse social determinants of health or adverse social factors? We noted that in this overall pool, if a patient had any social determinant of adverse social factor in the any social determinant of health domain, they had 47% higher odds, or 1.47 higher odds of having poor outcome compared to people who did not have any adverse social factors or did not have any adverse social determinants of health. This was the overall analysis. What we did in a secondary analysis was that we pulled out studies that only looked at race or sex as a social factor. So a lot of times when we include race and social or sex as a social factor and conclude on racial disparities, sometimes it might be considered as an inherent issue, or like genetics might be considered when we're talking about racial disparities. But there is a big interplay of social factors, and we wanted to strengthen those analysis or like strengthen our analysis by pulling out studies that were only looking at race as a social factor, because it's not a great, though it is a proxy, but it is not the best proxy for social determinants of health. So we've pulled out studies. We did have a lot of studies that looked at race or sex as a social proxy. After pulling those out, we noted that there was a stronger association and less heterogeneity in studies when we pooled studies that looked at any adverse social determinant of health present or not, and its effect on outcomes. And we now noted that patients who had any social determinant of health, not including race or sex as a social proxy, those patients had 74% higher odds of having poor outcomes compared to patients who had no adverse social determinants of health. So that was quite striking, that having any social determinant of health, whether it is an individual, community, healthcare, or health behavior domain, those were all associated with really could be driving the poor outcomes that we were thinking about, or we were missing that link. Yeah, this was the overall results.
So you also looked then at the social determinants of health as multipliers, and are they kind of snowballing in a particular situation? So that model, I think you show in figure 4 of the manuscript, and I'm wondering whether you could describe that for our listeners, because I thought that was actually a very good visual.
Yeah, so what we then did is that individually, or like at specific domain levels, all these factors were not adding, or like we wanted to see what the interplay was between different social determinants of health, because it might be quite possible that if a patient has multiple adverse social factors in different domains, they might have even higher risk or higher odds of having poor outcomes. So what we did is that studies that looked at more than two or more adverse social factors, we included those studies and then reran our subgroup analysis, and we noted that people who had social barriers or in different social determinants of health domains, they had a multiplied odds of having poor outcomes. To illustrate, we compiled that figure 4, and what we saw was that patients who had experienced racism or race was used as a social proxy and had public insurance, plus had experienced care fragmentation. So they were receiving cares in multiple clinics or different institutions. Those patients had 12 times higher odds of having poor outcomes compared to patients who had one of these adverse social factors or none of these adverse social factors. And what was interesting was that when we individual odds of different domains, when we added them, that was much lower compared to the odds of 12 times higher odds of poor outcomes that we were seeing on the analysis. So based on this result, we were able to at least say that maybe there is a multiplicative negative impact of having multiple outcomes, multiple adverse social determinants of health on outcomes. So maybe if a patient is experiencing multiple different adverse social factors, they might be at higher risk of having poor outcomes. And that could be our subgroup or high risk group where we could intervene and improve some of outcomes and advance health or survival of patients with lupus and lupus nephritis.
Yeah, and I love that graphic because it really contextualizes the concept that exposures of all kinds impact healthcare outcomes, and that each of those impacts doesn't happen in isolation. It really struck me that we've spent billions of dollars analyzing the genome and the microbiome and the metabolome, but we've not really studied the sociome. I'm going to ask you to speculate a little bit. Why do you think that is, and what would need to happen to move this research forward?
Yeah, that's a great question. And I think when we were designing this meta-analysis, that was in our mind, not there has been a lot of studies, or there when we were looking at when did these studies start? So the time period was very interesting. The studies on social determinants of health or like social disparities started to pop around late 90s. And there was a significant uptick in 2000s or like the late 2000s, and a lot of studies coming out in 2020s or 2019 to until now. What was interesting and what could have been missed early on, a lot of times we were using race and sex as social proxies. And when we bring those race as a social construct, but when we often bring just those two factors as proxies for social barriers, what happens is that maybe some lay audience might start thinking that that could be an inherent or a genetic problem with the groups. And it might not be perceived as the barriers that some people or certain groups might be experiencing. So by unfolding some of the associations or the interplay between different social groups and how it multiplicatively leads to poor outcomes, I think that was the unmasking or unfolding that we needed, and or the data that this meta-analysis provides. So that could have been missing, but a lot of researchers are already working on something called sociogenetics, how the social environment might be interplaying with the biological factors and leading to some of these outcomes that we are seeing in certain groups more than the others. And it also gives us a fair idea of what are the key social determinants of health that might be playing a big role in driving some of the poor outcomes, and how we can uniformly include them into, say, future studies, which should not be only intervention-based studies, but also epidemiology studies. When we are designing our observational studies, we could include some of these social determinants of health in the models and define an interplay or association, or at least control for some of the confounders, which we were not able to do earlier. And also, that would give us a better understanding of what's happening at the ground level and how to intervene and improve some of the outcomes so that we bring like equity forward and ensure that there are equitable outcomes in all patients with lupus and lupus nephritis.
Yeah, I kind of want to take you back to that initial review that you did of, I think it was somewhere in the region of 500 plus manuscripts, and then you kind of threw out the ones with insufficient data or insufficient quality to do your meta-analysis on. So you went from that huge number down to the 30 or so that you were able to do your additional analysis. And is there sort of a missed opportunity for trying to harmonize how we collect data on social determinants of health, and particularly across multiple diseases in the autoimmune spectrum?
Yeah. So, yeah, that's a great point. And so, what we also looked at, because we wanted to answer, like, if, say, for example, we say these are the key social determinants of health that we should look into. But in the meta analysis, but we also tried to understand what were the sources of collecting these social determinants of health. It was interesting that a lot of these studies, as we had thought about or imagined, were epidemiology or observational studies. So a lot of these studies just had registry data. And registry data, when it is collected at a population level, it's a rich data source, which has a lot of factors, a lot of variables that they have pulled into and they can control for. So while most of these studies were using registry data, and that could be using patient-facing questionnaires or clinician-facing questionnaires or other population-based databases, so interlinking patients' data from different sources, there were only a few studies that used electronic health record. So I think like that was something that is underutilized. If you look at the electronic health record, or EHR, more than 90% of the institutions across the country are already on EHR. So it gives us an opportunity to leverage the resource that we have. EHR has, if not all, but most of the variables on social determinants of health. And EHR has a wheel, social determinant of wheel. The major EHR, Epic, has a social determinant of health wheel. So if we do our due diligence of like collecting that data, not just from research perspective, but also from clinical perspective, because it gives us such rich information on what are our patients experiencing, and could be driving the outcomes that we're seeing, and also like gives us an understanding of why patients are non-adherent. Or a lot of times in our clinics, we have seen that patients are non-adherent just because they don't have that vehicle to go to the pharmacy and collect their prescription. So I think like that EHR is a underutilized resource which has all this rich data that could be uniformly collected. And once it is uniformly collected, it might be of much more importance to put all those factors or data collected again and see what the outcome or how it interacts or interplays with outcomes. And it might give us really interesting ideas of, here is what we can do. Here is how clinicians and clinician scientists can intervene. And this is how the outcome would change, or this is how we can make an impact. So I think like when we were doing that review, that came up as a significant underutilized resource. And then moving forward, that could be something studies could do or uniformly collect on, and think about interventions based on how things look in their geographic region.
I think that's really interesting. And it kind of dovetails a little bit with, I think, some of the data from the RISE registry, which shows that even in diseases where we have pretty clear guidelines on evidence base of, best treatment options, we're not able to get that treatment to the people who need it. And some of that is driven by social determinants of health, and kind of gets to this question of, are we really making an incorrect assumption that someone is non-adherent with medication willfully, or is circumstance creating that non-adherence because the pharmacy isn't able to fill the medicine because the insurance requires a prior authorization, but that isn't being explained in a way that anyone can understand it, and that message doesn't get back to the physician.
Yeah, exactly. And there are more and more studies now. We have a kind of opened a really, everybody is interested in the social area, social domain, how we can intervene because it was understudied or underexamined for such a long time that there is more and more literature out there and recent publications that highlight on economic insecurities. So a lot of times we don't think about like what if we step outside our doctor's shoes or clinician's shoes and think as a human in patient's shoes, I think like we often miss that part of what a patient might be experiencing, and especially in lupus and lupus nephritis it becomes very important because maybe 70% of our patients, or maybe larger number, 70 to 80% of patients are young. So young patients in the reproductive age group, they have kids, they have two jobs, they might have they might be graduate students, they might be doing PhD, they might have a lot of other factors that are going on, which we are not considering when we are looking when we are looking with a tunnel vision. So this whole concept of what the patient is experiencing and could be driving some of their responses and experiences and outcomes is very important. And I think like a lot of researchers are doing taking very important steps to unmask or unfold all these interactions, and we might be in a much better situation to figure out like what actual interventions we could make to bring back homogeneity in the response.
Yeah, I think that's a really good point. And when you're looking at some of these outcomes that you've been studying, so particularly cardiovascular outcomes, we know there are multiple drivers of that. And so, a young patient with lupus may end up on 9 or more medications, and the complexity of that treatment is going to impact the success, right? It's just very difficult to take that many medications a day, spread them out over the course of the day, take them at the right times, before food, after food. And I think we underestimate kind of the complexity of what that feels like at an individual level sometimes.
Exactly. And then on top of that, like I also think about like putting in the complexity of low health literacy, numeracy, and then language. A lot of patients who get lupus and lupus nephritis, we know that it also disproportionately affects women in the Latinx community or in the Hispanic from Hispanic ethnicity. So that brings up a even important discussion on when patients cannot speak English is their second language. So for that group, it might add another layer of complexity on what does these medicines mean and what are they doing to me. So that cultural appropriateness of discussion, the language, a leading journal published a paper on experiences of people in the Latinx community or from the Latinx community. And most of the patients highlighted that while going to a healthcare visit is a battle, so they called healthcare visit as a battle, the struggle with having a translator, not understanding directly or directly communicating with the healthcare team was an added issue or a factor that was driving non-adherence. So I think like it becomes really complex. It's like a web. It gets like once you start open it, it just builds on it and becomes complex really quickly.
Yeah. And I think part of the job of science and the scientists is to figure out kind of which components of that web are the important components where we can make the biggest impact to improve outcomes. So I'm going to change direction now, because talking of context and the importance of multipliers and the moving internationally, both as a patient and as a physician, I wanted to talk a little bit about your journey. And you, like me, are an international medical graduate. So American medicine is not your first language and it's not mine. So we all know about kind of translating in the medical context. You trained in India, moved to the US for residency. We've lots of listeners all around the world listening to this podcast. What advice do you have for fellow IMGs on becoming a physician in the United States?
Yeah, great. Thank you. I think a lot of times, and this is based on my experience, everybody's experience is so different as an international medical graduate. But from my experience, my advice or recommendation would be that we need to be comfortable with ourselves. We all come from different backgrounds, culture, accent. We come with an accent, at least like I came with an accent, and it becomes very true with people who are coming from or IMGs coming from Asia, East Asia, or Southeast Asia. So a lot of times, when I was thinking to come to the US, I was given a lot of advice about like fit in, and it might be a challenge fitting in. But one thing I realized is that the country, especially the medical community, is very welcoming to diversity. So in a country that welcomes diverse opinions, diverse people, we need to be comfortable with who we are. We need to be confident and comfortable with ourselves. Once I did that I was comfortable being a person, Indian origin, working here in the States, or and also like okay with my accent, I think like that gave me the most confidence and helped me connect easily with patients and medical community. So even if we are struggling, we need to just be comfortable and confident with who we are, accept ourselves before others accept us, because once we do that, everybody else will accept you for the person you are, and you really don't need to blend in, because sometimes our uniqueness is in differences or the diversity that we bring or the diverse opinions that we bring to the table.
Oh, thank you for sharing that. I think it's so important for people to hear. So, another important question that I ask many of our guests on this podcast is, at what point in your training did you decide you wanted to go into rheumatology?
Yeah, excellent question. So I had a few different moments. So the first moment was not many know that my one of my dear family members at a very young age got diagnosed with an autoimmune disease. And this is me talking about India 25 or 30 years back.
Mhm.
So really long time back. So Indian medicine is at a very different stage. So don't misinterpret me for the global listeners. India has advanced rapidly. So this might not be pertinent anymore, but this is like 30 years back down the memory lane when there was not enough research on autoimmune diseases, at least when I was growing up there. So, one of my dear family members got diagnosed with an autoimmune disease, ulcerative colitis, and she was just a young kid at that time, and she could not stop having diarrhea with blood and was losing all her weight and withering away. She got started on 16 different medicines,
Yeah,
and
amazing.
yeah, none of that was working, and she still continued to have diarrhea. And then at that time, in a country where bacterial gut infections were so prevalent, every time she went to the hospital, she got started on another antibiotic. So she got to a stage that I think she was scared, and my parents took her to this world or like the renowned institution in India, Chandigarh PGI, and the doctor was one of the leading peds autoimmune provider. So the first time he met the kid, she he asked her like exact. He could kind of sense like she was emotionally overwhelmed. She was not physically doing well, so just held her hand and said like, hey, what do you want from this visit? And she said, like, I just want to be a kid. Can you stop all these medicines? They are not working, and I cannot take 16 medicines. They make me feel miserable. And then I think like the first reaction of the peds rheumatologist was that, well, yeah, sure. Let's just stop 50% of your medicines. Would that make you happy? And she said, yes, hell yeah, it would make me happy. So for a person for a kid, 8-year-old kid with a differential diagnosis of acute leukemia on her list, she came out very happy from that visit. So clearly, there was a trust that the doctor built. And then at that very moment, it was very much like an eye opening experience for me, too, that maybe the healing touch that we always talk about the doctor. So that gave me a lot of insight on like something or a role model, something that I want to be, that maybe I want to be a doctor where I can help patients feel better, not just with medicine, but with that empathic touch or like by just understanding what they're suffering from. So I think like that was my first time that I thought maybe I want to become a doctor for a kid. And then at the same time, maybe rheumatology, because some patients are really in it and at a breaking point in their life, and we might be able to make a difference by just understanding and helping. So that was one experience, and then obviously that was a young experience. And then when I went into medical school, I think the reason that I took rheumatology was the reason a young 16-year-old kid came in with lupus nephritis, delayed diagnosis. By the time she was diagnosed, her kidneys had given up. And then we saw her wither away, just trying to arrange funds to support her dialysis because the family was from a rural background. They did not have enough economic resources. So we saw that was very impressionable moment for me. Like 17 or 18 years old, we go into medical school in India. And I just could not forget the experience of being a girl who was almost my age, dying or not being able to save because we could not diagnose her sooner. So both of those are like, and there are several more moments that drove my decision to become a rheumatologist. But I think like those were the key ones, which I remember that made me or urged me to think about rheumatology and become
Yeah.
a rheumatologist.
Amazing. Amazing. Thank you for sharing that. Were there mentors who acted as multipliers in your life, helping to catalyze your career?
Yeah, it is very difficult to do a lot of things, I think, without mentors or like have the guidance. So I was fortunate enough to have life mentors and career mentors. So life mentors always helped me with decisions, hard decisions, like coming here 15 or 16 years back when I decided to come here. So my life mentors obviously include my parents, and then being the first doctor in my immediate family. So it took a lot on their part to guide me. They were not from the medical background. So just like finding resources, connections, and trying to send me all my by myself at a very young age of 18 or 19 was something that required strength, but they were always there to guide me. And then talking about life mentors, I am again fortunate to have a life partner who not only understands but also like critically helps me think critically. So there are a lot of times when I might be overwhelmed or like I might be thinking in one direction with a tunnel vision, but he helps me understand that maybe there might be a different aspect that definitely helps support the career that I'm trying to build. And then it might be again like empty. So I think like the biggest exponential or multiplicative effect that I had were from career mentors. So there are several career mentors. And I wanted to highlight a few. Sam Lim, Dr. Lim has been a great career mentor from the get go since the time we met during my fellowship interview. He started guidance like through that interview into fellowship and continues to be my career mentor, career and research mentor. Dr. Christy Bortles is another division chief here. She has been a strong pillar of support in thinking 4 steps in advance, how one study might lead to like different studies in the future, or what could be the cascading effect of the research that I'm building. And then several others, including Dr. Asper here, Dr. Raval, and then I think Dr. Diet at Emory, Dr. Burton at Oregon, Dr. Roven at Ohio State. So I have been very fortunate to I find mentors, collaborators who have served as mentors at certain point and helped me balance out my life as well as build a small niche for myself.
Oh, that's wonderful to hear. So you have a web of mentors too. So in preparation for our discussion today, I did a little bit of research myself, and you have been quite prolific, both in publications and in collaborations, which made me think that you yourself might be a bit of a multiplier. Do you have any advice for the people listening? How do you get it all done? What's your secret?
I think there is no secret, but I was trying to think what could be the secret, or what could be the secret recipe for those of you who. I'm also an avid music listener. So a lot of times what I do is that I try to bring up songs that relate to my situation, or to relate to some of similar questions. So I think like this song kind of makes total sense of what even like more renowned and like more established people might be doing. Is the song which I wanted like could be the secret or the secret recipe to anybody's success is the Remember the Name by Fort Minor. So the songs goes about like talking about like what is success made of, or what is like what are we working towards, and then it says that it is 10% luck, 15% hard work and skill, 20% concentrated power of will, 5% pleasure, 50% pain, and then 100% reason to remember the name.
Oh,
So yeah, while a lot of this is still a work in progress for me, but I think like it kind of resonates with a lot of people who are trying to balance being a clinician, being mom at home, being a wife at home, and then or like vice versa, just being spouse at home, and at the same time build their research career, which takes a lot into. So I think that kind of resonates as a secret, or maybe like a recipe. And then the final thing, which I thought that could be that whenever I come back to like, why am I doing this? We all come to that moment of like, well, is it worth it? So I go back to that moment when my family member was struggling and how this doctor helped. So I try to be that physician or the physician scientist in my mind, where I want to like do a 50% with words and empathy and being a human, 50% with my research and science. And then I put a 20% extra to be a human in patients' shoes and start thinking about like what they are experiencing or what their experiences could be, so that I can think a little bit out of the box and hold their hand through this journey. And then 5% is never giving up kind of approach, which might be not 5% of it, much significantly higher, but that's where life mentors and career mentors play a role.
Oh, I love it. Thank you. Thank you, Shivani, for sharing all of your work with us today, but also your secrets of success as a multiplier. It's really been a great pleasure chatting with you.
Thank you so much. I enjoyed my time, and thank you for the invitation. Really appreciate it.
So my thank you today also goes to positive multipliers, particularly those who are willing to collaborate on difficult early stage projects with early stage investigators with limited obvious early rewards. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.